Good evening and welcome to my YouTube channel Pain Free Partha. And most of the slides are available and freely downloadable, editable in my website www.painfreepartha.com. Today's topic is about the recent advances question paper from MD Anesthesiology, Cytokine storm. Now, the patient comes to you with a simple viral infection, corona infection. Within a few days, the lungs fail, BP collapses, kidneys stop working, patients lands ICU. Now, we know that this infection is not causing the damage. Corona itself is not causing the damage. Some virus is not causing the damage. So the body's own system causes the damage. This is called cytokine storm. Now, cytokine storm, it describes a spectrum of clinical manifestations. It may be lung, liver, kidney, coagulation, or anything. What is it due to? Increased cytokine levels. What is it due to again? A dysregulated immune response. A cytokine is a tiny chemical messenger. What is a cytokine? It's a small chemical messenger used by body's immune response. Now, cytokines are WhatsApp messages sent between immune cells. Okay. Now, there is some infection coming. The immune cells could start fighting the infection, start fighting the bacteria. This is the WhatsApp communication. Okay, this is the cytokine. If this is released in high damaging things, then it becomes a cytokine storm. So it is police like soldiers and phone calls and messages. Messages are cytokines. So what's the danger? Excessive immune response. Instead of attacking the infection, it starts attacking the kidneys, lungs, etc. That is what is important. This is what is cytokine storm. Again, I am telling, during the COVID-19 pandemic, many patients did not die because virus destroyed. It is because of the exaggerated human response. Now, imagine a small fire in the portico, okay? And the firefighters, 3, 4 are coming and controlling the fire. Now, if the firefighters think that their fire is everywhere and 100 people come and start pouring water everywhere, what will happen? The veranda will get damaged, the glass panes will get damaged, the roof will get damaged. That is what is called cytokine storm. Now, there are a lot of cytokines, fever, IL-1, interleukins, TNF-alpha, interleukins, IL-10, CRP, ferritin, so many are there. So we can easily measure CRP, ferritin, and possibly interleukin-6. Excessive release of ILs, TNF interference from immune cells, they can cause all these problems, system complications. So, where it will occur? What are the settings in which this cytokine storm can occur? Yes, it is sepsis, COVID-19, influenza, ABV infections, so many infections. It can also cause in cancer immunotherapy. It is possible in autoimmune diseases like Still's disease. HLH, hemophagocytosis lymphocyte histiocytosis. Primary or secondary. This is not uncommon. I have one patient with me. Malignancies, lymphomas, transplantation reactions, GVH response, toxic shock syndrome, severe illnesses. So, what I want to tell is, it is possible in infection, it is possible in non-infections like malignancies, reactions, autoimmune, etc. Now, this is the pathophysiology. Now, infections or immunotherapies or malignancies or autoimmune, all these things causes an immune cell activation, causes the cytokine release. It may be interleukins, TNF-alpha, vascular endothelial growth factors, etc. And this cytokines causes further cytokines to come. This is what is called immune amplification, and they can cause coagulation, BP fall, tissue injury. Okay. Now, this can cause lung, heart, liver, kidney, brain encephalopathy, and coagulation. So this will lead on to dangerous life risk. Now, how these things occur? Okay, it affects lungs, kidneys, etc. Cytokine excess can cause endothelial injuries. Cytokine excess can cause capillary leak and dilatation. So coagulation, activation, and microthrombosis. It can cause cell damage. It can cause mitochondrial dysfunction. So all these things can cause tissue hypoxia, inflammation, coagulopathy, and organ dysfunction. For example, here it may be capillary and pulmonary edema. It may be here DIC, or it may be tissue injury here. Yes, that is what capillary leak can lead on to pulmonary edema, vasodilatation can lead on to shock, microthrombosis can lead on to this, mitochondrial dysfunction can lead on to cellular hypoxia, and multi-organ dysfunction syndromes. Why in cancer? So infection, we know something is happening. Abnormal blood cells continuously send danger signals. So, and these danger signals are thought of as major threat by immune cells, keeping cytokines really. Now, you think there's a school security system, okay? The infection is the real thief. Thief is entering the school and the alarm goes on. So, if there is a faulty sensor and the siren goes on, goes on, goes on, then it becomes cytokine storm. So it may be respiratory, cardiovascular, cough, dyspnea, ARDS, hypotension, shock, headache, confusion, delirium, nausea, vomiting, diarrhea, elevated liver enzymes, jaundice, kidney failure, coagulopathy. So all these things are possible signs and symptoms of cytokine storm. So this is what is fever, BP fall, hypoxia, coagulopathy, and multi-organ failure. This is the main slide which we need to know. What is the timing? Maybe hours to few days in certain cases, and in malignancy, it may be over days to weeks. So we cannot say now his COVID-19 usually the second week is dangerous. Infection, it may be few days only, 1 or 2 days. So that is what is the idea behind this timing of cytokine storm. Suspect cytokine storm when there is a persistent high fever, CRP, IL-6 elevated, cytopenia, ARDS, multiple organ dysfunctions. Is not only sepsis, it is cytokine storm associated. Now, why general certain people get cytokine storm and not all of us? Because there is a genetic possibility. The patient itself is having some comorbid illness. Infection or the inflammation or the autoimmune disease is very severe, or the brakes fail easily. The regulation is weak. So these are all the patients or the influences. Now we know what are the settings. Settings is maybe sepsis, immune, autoimmune diseases, malignancies, cancer therapy, etc. These settings, certain genetic and infection is heavy or the inflammation is heavy with a comorbid illness, then these people go on to cytokine storm. Sepsis can trigger cytokine storm, but all sepsis is not cytokine storm. Severe sepsis may progress to cytokine storm. Okay, sepsis means is a dangerous multi-organ dysfunction. But this MODS could occur because of a dysregulated immune response. Then only it is cytokine storm. Now you can see life-threatening organ dysfunction, but here there is a bacteria or fungus. There is not, may not be there in cytokine. It's an infection and immune response, mainly immune response. Cytokines are markedly elevated, and fever is common and very high. Organ failure, massive inflammation can occur without infection. So the treatment here is immune suppression. Also, here antibiotics and source control. Some practical CRPs are very high, ferritins is very high, D-dimer may be very high, platelet count is less, IL-6 may be very high. So all these things point out to a cytokine storm. Yes, similar features or differential diagnosis in sepsis, HLH, severe autoimmune anaphylaxis, etc., DIC, pulmonary embolisms. What is in relation to anesthesia? Yes, they cause ARDS, they may be shock, there may be people call for sedation strategies, mechanical ventilation, sepsis differentiation, and it may even occur as a perioperative cytokine storm in patients with sepsis. Treat the trigger, control the inflammation, support the organs. Treat the trigger means what is the trigger? Infection is the trigger? State. Control inflammation by steroids. support organs by vasopressors, whatever it is, renal replacement therapy. The major treatment is dexamethasone or methylprednisolone, 6 milligram IVs PU once daily. This is very interesting and simple treatment for an MODS due to a cytokine storm. Yes, we can use tocilizumab, 8 milligram per kg IV. It comes as 12 to 24 hours. We can use anakinra, IL-1 blockade. Biological agents are effective but expensive and may not be available at all centers where we need to come from other place. It may take one day. HLH specific therapy like etospide or cyclosporine. I am not going to the details of these therapies. Predominantly think of dexamethasone 6 milligrams because it is not involved much in anesthesia. Yes, we may need to add enoxaparin. So how frequently CRP may be daily, but IL-6 may be every 3 days. ABG oxygenation, yes, as needed. Because cytokines are very short half-lives. If you go and the test comes after 2.5 days, there is no use. Yes, fever decreases, ferritin falls, oxygenation improves. Clinically, the patient is better, conscious, less need of noradrenaline. All these things make the patient is improving. Yes, it is a vicious cycle. Infection causes immune cell, massive cytokine release, endothelial gap, tissue hypoxia, more damage, more cytokines. Again, this is what is called vicious cycle. So give anti-inflammatory, give antibiotic here, stop the cycle here. That is what is again. Otherwise, go on. Because symptoms mimic severe infections. Cytokine assays are not available. A single diagnostic test. I am doing prosthetic specific antigen. It is clear. So such things are not there in cytokine storm. Clinical judgment is essential. Yes. What is the future perspective in cytokine storm? Better early biomarkers. If they're available, okay. Targeted immunotherapy, IL-6, IL-1, some are there, tocilizumab and anakinra are there, but better drugs, cheaper drugs should be available. Faster infection diagnosis. In cytokine storm, the enemy is no longer an infection. The immune is also an enemy. Early treatment and timely treatment can prevent multi-organ failure. Thank you very much for listening and visit me at Pain Free Partha. Thank you all.